BC Pediatric Society educational event. And I have known Sylvia since she arrived at our hospital in 2005. And Dr. Stockler has been a wonderful addition to our department. And to say before I start as well, I want to welcome George Davidson, who, for some of you who won't know George probably, but George was an incredible pillar in our hospital for decades, and gastroenterologist, and saw lots of metabolic disease. And he is the one who is the founder, really, of our milk bank, which has been running for 40 years. And so, yeah, welcome, George.
Thank you.
And welcome, Sylvia, and all the rest of you. Anyway, Sylvia was born in Austria and did her medicine at the Karl Granz University in Graz, and her postdoc in biochemical genetics in Graz, and then her residency in both Zurich and Graz, and her fellowship in pediatric neurology in Göttingen, Germany, where she was on faculty from 1992 to 1995. And then she was at the Vienna University of Bus in business administration, where she did a fellowship in lab medicine. And then she got an MBA from Vienna University in business administration. And very early on in her career, developed a real interest in rare diseases. And she arrived here with her husband, Osmond Ipsariglu, who I think many of you know in developmental pediatrics, and has been a tremendous and powerful addition to our Department of Pediatrics. And I just had an example illustrated yesterday of how important it is to diagnose rare diseases. I've been following a little girl since she was 2 or 18 months with an undiagnosed syndrome. And she's been seen by everybody. She had congenital heart disease, she had heart surgery, and she had certain very abnormal facies and abnormal teeth, and she developed rheumatoid arthritis. She had anemia and thrombocytopenia that were poorly explained, and she had several genetic diagnoses, including a variant of Noonan's, and one of the more recent ones was floating harbor syndrome, which I had never heard of. And you're like, how can I get to my age and never hear of a syndrome like this? But then she came to the causes clinic, and her exome sequencing was done, and she has Kabuki syndrome. And you think, well, that doesn't change things very substantially, but these parents were in my office yesterday, and they are so thrilled, to have an actual diagnosis that puts all these variant pieces together has been incredibly affirming to them that there is an answer. So, Sylvia, we really are very grateful for the contributions you've made in our department. And tonight she's going to talk to us on the developments in the diagnosis and treatment of genetic diseases, a pediatrician's perspective. Sylvia.
Well, Paul, thank you very much for the kind introduction, and thank you very much to the BC Pediatric Society for giving me the opportunity to talk to my colleagues, to all the pediatricians, and thank you, Shire, because Shire has kind of tried to convince me that I really should do that. So here are some disclosures. So we have been involved in industry-sponsored trials, in industry-sponsored registries, have received educational grants, and are doing research collaborations, and all the companies that you see here are the big leaders at the moment in biochemical genetic diseases, but there will be more and more coming up. For example, the one that I mentioned at the end, there are many small companies who are developing new drugs for rare diseases. So as an outline, we have a big program. I hope I make it in time. So I would like to talk about our initial approach to screening for treatable intellectual disabilities, and will shortly summarize our TIDE and our TIDEX studies, which some of you have heard about. Then I will talk about new generation sequencing in clinical practice. So with new generation sequencing, I mean exome sequencing or gene panels. These are all tests where you don't look just for one gene, but you look for many genes at the same time. And I will try to explain you the advantages, the opportunities, and the challenges with some case vignettes. I will shortly talk about treatments, about the traditional treatments that we're having now and innovative treatments that come up, and about challenges in evidence-based medicine for those treatments, because we're speaking all about very rare diseases. And finally, some questions and answers, questions that are frequently asked in terms of consenting, secondary findings, and genetic discrimination. And finally, with all that, I would like to initiate some discussions with you pediatricians in the community. How can we develop a new model of care for those patients? Because these are all extremely complex patients, not only complexity, clinical complexity, but also the results that we obtain from the exome sequencing are very complex, as you will see, and they all need follow-up. So first part, treatable intellectual disability. What is it? So biochemical diseases, inherited metabolic diseases, are a paradigm for treatable genetic intellectual disability. And the paradigm diagnosis is PKU, and all of you know PKU. And this goes back to the early 1990s when PKU was discovered, and to 1950s when diet therapy was developed, which proved very efficient in preventing the symptoms, and therefore a newborn screening was developed in the 1960s. And finally, based on this newborn screening, with new technologies, we are now screening for many more of similar diseases. More than 40 treatable disorders are now included in, not in all, but in some newborn screening programs. And there are more treatable intellectual disabilities and treatable genetic disorders, which are not yet included in the newborn screening for various reasons. But this doesn't mean that they're not treatable. So how does rare biochemical disease and intellectual disability come together? Well, intellectual disability is frequent. So 2 to 3% of children and adults worldwide have intellectual disability, and more than 50% are known to be genetic. There's more and more. We're now thinking that 60% are genetic intellectual disabilities. So, and most of them are combined with neurologic, psychiatric, or somatic manifestations. So intellectual disability on its own is rare, so you always have other conditions. That means that it spans many, many children who have developmental problems. The microarray or chromosome test has been considered as very efficient because it has a high diagnostic yield. But most of the diagnoses that you achieve with a microarray will be diagnoses that are syndromic and where you don't have a treatment. So biochemical diseases are a very small proportion of those 50% of genetic intellectual disabilities, but many of them are treatable with a causal therapy, like PKU, where when you recognize it early enough, you even can prevent the whole manifestation. So that's why Clara van Cannebeck and myself tried to find out how many of these treatable inborn errors or biochemical diseases do we have which cause intellectual disability. And we did a systematic literature review, and we found treatable inborn errors of metabolism causing intellectual disability across the spectrum of biochemical diseases, so affecting amino acids, organic acid, metal disorders, carbohydrates, and so on and so forth, down to peroxisomal and lysosomal disorders. So lots of diseases where we have already treatments. And based on this literature review, we developed a protocol that would help us in a standardized way to screen for these disorders. And this protocol actually comprises 3 tiers. The first tier is the one tier that should be done in all children with unknown cause of intellectual disability. And it's biochemical group tests. It's tests like amino acids, organic acids, which are easily available and which are not invasive because it's just urine and blood. And these tests would cover 60% of these treatable intellectual disabilities that we found in our literature review. Of course, only 60%. So what's about the rest? For the rest, we have developed a second tier, which more precise clinical phenotyping. So there needs to be somebody who knows about those diseases, because in the second tier you have to order specific biochemical or genetic tests to diagnose these patients. And finally, the third tier is the next generation sequencing, meaning that if we don't find a diagnosis, this is the ultimate goal to do is to test those patients with next generation sequencing, for example, whole exome sequencing. And as you will see, we're doing more and more exome sequencing, and there's a little bit a change in the order. We're doing more and more exome sequencing before we do the second tier, because exome sequencing just has become so effective. And of course, this all is on top of the current practice parameters. We don't say don't do what everybody has been doing so far. Of course, we still want to do microarray MRI of the brain to see whether there's some brain malformations, and of course to do hearing and vision tests to see whether this could be part of the developmental delay. So we did a tight study that was funded by the BC by our hospital, and in this study we investigated about 500 patients where we did a very precise phenotyping. So all their clinical data went into a database, and as you see, those patients were across the ages from very young to 19 years old. And the degree of their intellectual disability was, most of them had just mild to moderate intellectual disability, and most of them had comorbidities. As I mentioned, intellectual disability usually is not on its own. There are lots of comorbidities. So most of them, half of them had psychiatric comorbidities, autism, for example, epilepsy, or dysmorphic features. And in all these patients, we could establish a diagnosis in more than 50%. And as you see here, treatable inborn errors of metabolism were accounted for about 6%. Again, this is not a lot, but still it's good, because these patients have now the chance to be treated. And it's also adding to the literature, because previously people thought that it might be that the yield for this kind of screening might only be 3%. So this means that if you do it in a systematic way, you can achieve a diagnostic yield in this group of disorders of 6%. Of course, we found lots of chromosomes, and yeah. So you have a question.
I just wondered, Sylvia, do you know if they don't have epilepsy or dysmorphic features, they just present with intellectual disability plus or minus some psychiatric comorbidity, do you have any idea what the yield is then?
Yeah, I don't have this data ready, but I think the yield is quite high if they have.
Substantial.
Yeah.
Okay.
There's no. Yeah. I mean, I honestly, I'm seeing lots of patients, but most of them have some psychiatric comorbidity.
Right.
If we count autism as a psychiatric disorder, but most of them have some psychiatric comorbidity. Those who only have autism, who only have high functioning autism, as we spoke, the yield is much lower, but they don't have intellectual disability.
Right.
So how did we? Yeah, well, let me just. And then we also started doing exome sequencing in those patients. And of course, this was a very selected group of patients where we did the exome sequencing. This all happened in 2012, 2013, when these methods were not yet available clinically, so we had to do it on a research basis. But you see that those patients that we chose for exome sequencing, in most of them, we could establish a diagnosis. So how did we implement and evaluate the TIDE protocol? The TIDE protocol is really something, the success of the TIDE protocol really depends on you pediatricians in the community, because the first year, either you do it yourself or you refer the patients. This is really something that is done in the community. And that is why we tried to work together with you and to implement it based on a consensus building workshop, and which 19 BC pediatricians participated in this consensus building workshop. And this workshop, actually the result of the workshop was just that we worked out what is the best way that the pediatricians can order these tests, what would be red flags if you get those results back, so that there is some kind of that you feel confident with doing those tests. And we finally also evaluated it after a while, and still 13 pediatricians took part in the survey, and most of you were quite satisfied with that TIDE protocol because you felt that it really improved the diagnostic workup, that you had a kind of protocol how to start a diagnostic workup. And so that's also kind of resulted in a change in practice. And this was published in the BC Medical Journal. So part of the implementation was also to develop some TIDE tools, and the most prominent one was that is the Treatable Intellectual Disability app, which is available as a web app, but it's also available in the Apple App Store. And it just gives you some overview of all the diseases, the treatment options, and also a possibility to do some differential diagnosis based on combination of symptoms. So I would like to give you just one example of a treatable intellectual disability that can be detected by the first tier, just by urine tests. And this is GAMT deficiency, and I chose this example. It's a very rare condition, but we identified 3 patients in the with the TIDE protocol, and overall in the world there are only 100 patients known. So that means either we have a lot of patients with this condition here, but I don't think we have a special population. But it's probably because if you do it in every patient who has intellectual disability, you will find it, and also because this all led to the implementation of newborn screening. So this is just shows you where is that disease located. Here you have the creatine, which is deficient in those patients because this step, the GAMT, is not working. And the patients who have this problem, not only that they have low creatine, but they also have high guanidinoacetate, GAA, which is pretty toxic for the brain. So the brain suffers because of the toxicity of the GAA and because of the lack of creatine, which is important for energy generation. Creatine is synthesized in the liver mainly, but the liver is not affected. These patients do not have liver disease because the liver wants to get rid of the creatine and the guanidinoacetate quickly because it's needed mostly in the brain and in the muscle. And those patients mostly have a brain condition. So how does this condition present? It's pretty unspecific. On a clinical basis, it would not be possible to make a diagnosis. So these children have intellectual disability or developmental delay. Many of them have autism. I have seen children with catatonia with this condition. Some have epilepsy, and in some of them the epilepsy is really severe and intractable. Many of them can have dystonia or CP-like symptoms, and this can be due to basal ganglia changes. They also have poor weight gain and don't grow well, have osteopenia. And if you do an MRI and an MRS, you will find a very low cerebral creatine, which is a good marker. But the actual diagnostic hint is provided in the urine by the purine and pyrimidine test that our lab performs for us because of that high guanidino acetate. So this is the diagnostic marker for this disease. And of course, you have then confirm it with a mutation analysis. But if you have a patient with high guanidino acetate and with low cerebral creatine, a couple of years ago, when we didn't have access to all these genetic tests, we would have said, well, this is the diagnosis. And I also chose this condition because it tells us about the treatment, about the nature of treatment of these disorders. So again, let's I want to remind you that we have a deficiency of creatine and an accumulation of guanidino acetate. So the deficiency of creatine is easily treated by substitution of creatine. Creatine can be substituted orally. It's not expensive. It's available. It's also in health stores available for athletes. So it can be given orally, and it works very well. So if you give those patients creatine, their creatine in the brain will rise. It will normalize. It passes the blood-brain barrier. The reduction of the guanidino acetate is a bit more challenging, but this is the nature of many biochemical diseases, that we have to treat accumulation of substances. And the way how we treat the accumulation of substances derives itself from the biochemical pathway here. So in order to make sure that we don't produce too much guanidino acetate, we, on the one hand, reduce the arginine, which is the rate-limiting substrate for the guanidino acetate production, by an arginine-restricted diet. So those patients would have a low protein diet. And on the other hand, there's a little bit of a trick, because if you give those patients a lot of ornithine, the ornithine will automatically shut down this enzyme, and then the enzyme doesn't work well, and then very little guanidino acetate is produced. And we have a couple of patients now where we are not able to work with the arginine restriction because they don't tolerate the diet, they are not compliant. And where with very high dosages of ornithine, we achieve a very good result. And the outcome is really amazing, because not only that you have a normalization of cerebral creatine, which is a biomarker, which per se doesn't mean much, but there is an enormous improvement of epilepsy and dystonia. In most of the children, this normalizes. They don't need any medications. There is an improvement of mood, behaviors, variable improvement of intellectual disability, because this is an irreversible process, and if you are already old enough and far in the disease, it's difficult to reverse it. But of course, they also have improvement of weight gain and growth. And here you see an example with a treatment response of such a patient. Again, it's just such a classical biochemical genetic phenotype that shows us the beauty of the treatments that we have for those children. Here you see the patient before the treatment, no creatine. This is the normal creatine peak, that's just not there. And here, after a while of treatment, totally normal. Here you see a significant improvement of the EEG after a couple of months of treatment. And here you see that even basal ganglia changes can be reversible in those patients. We did a study on about 50 patients worldwide with this disease, and what we found is that there is a negative correlation between the severity and the age. So the older the patients are, the more severe is the degree of intellectual disability. So this tells us that there's a progression somehow, and it also tells us that maybe when we really catch it very early, that we could, like in PKU, that we could hopefully prevent the whole problem. And that is why there are a couple of countries and legislations that have introduced the newborn screening for this condition, and among those countries is also BC, and I'm very proud of that. In BC, this has been implemented in 2017, so all the blood clots that come in from newborns will be routinely screened for this disorder. And the good thing is that this was not associated with any costs, because it can be integrated in the platforms for the other tests that we have for the newborn screening, because the guanidino acetate goes together with the amino acids that we're looking for the diagnosis of PKU or of maple syrup urine disease. And here you see all the other countries' legislations that have introduced a similar screening, and altogether approximately 1 million children have been screened for this disorder in all these legislations, but unfortunately no positive diagnosis so far. So is it really so rare, or is the screening not efficient? We don't know. Most likely the screening would be very efficient in Portugal or in populations where the Portuguese community is very prevalent, because they have a founder effect which is pretty frequent there. So Portugal is not screening at the moment, or Brazil, these countries where you have these populations, they might find quite a few patients. Now, TIDE is good. TIDE helps us to find these classical metabolic diseases, but as mentioned, they are really rare. And there is a lot of other patients out there who will not be diagnosed with the first tier. But the first tier screening is an entry of the patients into more diagnostic workup. And what we did while we were doing the TIDE project, we created something that's called TIDEX, where we looked particularly at patients that had a whole exome sequencing, so a type of next generation sequencing, as part of their diagnostic workup. And we looked at children who had intellectual disability with an unexplained metabolic phenotype. So if they had, let's say, low blood sugars or some abnormalities in the organic acids, which we couldn't explain, or where we couldn't find a diagnosis. So we took them all and took whole exome sequencing. The reason why we did it was that we were hoping that having the unexplained metabolic phenotype would finally help us in interpreting the results of the whole exome sequencing, because the whole exome sequencing doesn't tell you this is the disorder of the patient. It gives you many, many genes, and you as a clinician have to find out what is the gene that is most feasible in that patient. And so we hope that when we have a metabolic abnormality, that we could kind of guess the pathway that could be affected, and that we could be more successful. And indeed, we were able to establish a diagnosis in almost all of them with this approach, because we had the metabolic pathway as the kind of hint for the interpretation of the results. And we found two new gene defects that never had been described before. We found a few gene defects that also never have been described before, but where we only had one patient. So it doesn't, per definition, it's not a newly identified gene defect. You have to have a few patients who have the same problem. And we found 22 known genes that had new phenotypes. So where the phenotype wasn't really known that it could be caused by that particular gene. And we also found, of course, a few gene defects where we knew where the phenotype was known. So since the TIDEX program, which was kind of finished in about 2015, we learned a lot about exome sequencing, and there was a lot of development also for clinical testing. Now we have many labs who are doing that on a clinical basis, and that is why we are now more and more getting into the clinical adoption of next generation sequencing. Most patients that we're now seeing in our clinic don't have exome sequencing in the context of a research project, but they have exome sequencing in the context of a clinical test. So in 2016, in our division, in the Division of Biochemical Diseases, we had about 300 new referrals, and out of those 300 new referrals, we decided to do next generation sequencing in about half of them. And you see here whole exome sequencing in about 50 gene panels, where you just look at particular genes, but at more than 10 genes most of the time. Sometimes it's hundreds of genes. Or we did, of course, still some exomes, research exomes, mostly as part of the causes clinic. And the diagnostic yield of those clinical exomes, so of those almost 80 exomes, was that we found a diagnosis in more than 50%. And interestingly enough, these were all disorders which we would not have been able to detect on the basis of a biochemical test. So it's really the exome that you need to do in order to get a diagnosis. So now I'm coming to a few examples of next generation sequencing. And again, when I speak about next generation sequencing, it's either gene panels or whole exome sequencing, and now pretty new and still much more on a research basis, whole genome sequencing. But before I come to those examples, I would still speak about the value of microarray, because you remember at the beginning I said, well, a microarray really gives you a high diagnostic yield for these disorders, but most of the disorders are not treatable, and that's why we developed the Treatable Intellectual Disability Project. But on the other hand, the microarray still has a lot of value, which you will see in a couple of cases. So microarrays can detect either deletions or duplications of a sequence of coding or non-coding genes on a chromosome. And when I'm speaking now about microarray, I'm speaking mostly about deletions, because if something is deleted, it's clearer, it's more feasible that it might make a problem. We do not yet understand very well what happens with the duplications, but of course, as we know from Down syndrome, which is a duplication of a whole chromosome, that, of course, duplicate too much of a gene also can make a problem. It's just that we don't understand it yet. So if you have only 50% of a gene dosage, because on one allele there's a deletion, then you can have a problem. And if you get back those microarray results, I think you can order them in your practice, and you get back a lot of results. So, what is the scenario? You can have benign changes. They are benign because they are frequent in the population. So all of us have all kinds of deletions in our chromosomes which don't affect us. Then you can have some potentially pathogenic deletions which need to be further validated, because if those deletions are parentally inherited, so that one of the unaffected parents has the same thing, it's not very likely that it causes the condition of the child. So that is why, as a second validation step of those microarrays, we are also testing the patients. The only way where the microarray findings are most likely pathogenic are if they are de novo. That means if they are just occurring in the patient. And most of these patients have syndromes where organs and systems are involved, not only the brain. Here's a very interesting example. A patient whom I saw last year, 12-year-old female with congenital sensory hearing loss, and she had a gamut of problems, intellectual disability, challenging behaviors, new onset of behavior, scoliosis, and then she also had migraine with 2 hemiplegic episodes. So how does that really fit together? For developmental delay and challenging behaviors, obesity, I mean, that still makes sense that it could be a genetic syndrome, but is that migraine something that the patient has in addition, or is it something that all belongs together? So the result of the microarray showed that she has a 16p11 deletion, and this is a region of that chromosome which is very dense in genes that are OMIM. That means these are genes that are known to cause genetic defects. So it's a very very low doses of carbamazepine. So it's much lower than you need for treatment of epilepsy. And whole exome sequencing would not have helped to establish the diagnosis because whole exome sequencing is not able to detect the deletion. The whole exome sequencing only detects if there's a change within the gene. There are other microdeletion syndromes. The one that you know well is the DiGeorge syndrome, which is 22q11. And it's also a region where there are lots of genes on it. And I just recently saw a 17-year-old female with intellectual disability, long history of hypothyreosis, growth retardation, submucous cleft palate, celiac disease, and anxiety and gender dysphoria, so also some psychiatric problems. Again, is this something, does this child have 2 diseases or 3 problems? No, it's the 22q11, which can explain everything, including the celiac disease. And there are other conditions, like also on the X chromosome, you can have, disorder. On the X chromosome, there are some loci where you have a lot of genes, like intellectual disability genes, muscular dystrophy, OTC genes. So now, first example for next generation sequencing. So with next generation sequencing, there are a lot of quite a few scenarios. This is a patient who seems to have multiple phenotypes. Again, seems not very related with each other. But finally, we were able to find out that this is all due to a single gene defect. And this is a 17-year-old male with autism and psychiatric manifestations, and also a new onset of celiac disease. He lost a lot of weight, vomiting, and so finally the celiac disease was diagnosed even with a biopsy. And he also has a long history of recurrent mono and oligoarthritis, so he has been seen in rheumatology for quite a while. And the interesting thing is, when I saw the child, I was lucky because it was cold, it was in the winter, and he had chilblains on his feet. And the parents told me, well, this is something that he has always when, it comes and goes, but when it's cold, he has chilblains. So chilblain for me was the kind of trigger to look at disorders that are kind of summarized under Aicardi-Goutier syndrome, like disorders. These are disorders that are gene defects, a couple of gene defects that cause interferonopathies, and these interferonopathies not only have an adverse effect on the brain, but also on other organs. So this is now a defect where we have one single gene defect, so this patient has one mutation on a gene which causes all his problems. Second example, there are also children who have one phenotype, but who finally turn out to have 2 different genotypes. So we have more and more those cases where we have more than one genetic defect that explains the problems. And this is a 6-year-old boy who was seen for myopathy. He has a history of congenital arthrogryposis, and he was quite disabled, but he was able to walk, but only for short distances. He was quite weak. He wasn't able, for example, to open the refrigerator because he was so weak also in his arms. And with the next generation sequencing, we found 2 gene defects, actually. The one is the COL6A3, which causes a known congenital muscular dystrophy, type Ullrich it's called. And his clinical phenotype actually fitted very well into this diagnosis. But we also found that he has a partial deficiency in the riboflavin transporter. So this is totally unrelated. The riboflavin transporter is important to get riboflavin into the mitochondria, and the riboflavin in the mitochondria is needed for fatty acid oxidation. So he also has a kind of fatty acid oxidation defect, and we saw that in the acyl carnitine profile already. And if you are not able to oxidize your fatty acids, you will also have muscle weakness. So this is why we still, although this congenital muscular dystrophy was so prevalent in the diagnosis, we started treating this boy with riboflavin, and he improved significantly. I mean, of course, he wasn't cured from his primary condition, but he improved in muscle strength, and he's able to open the refrigerator. He has a little bit more walking distance, and he's doing much, much better. So you also can improve something in those children. Other example, next generation sequencing can confirm a clinical differential diagnosis, which you make already on a clinical basis. This is a 17-year-old girl who came with a history of intellectual disability, growth retardation, late onset hemiplegia. So she didn't have hemiplegia from birth, she just developed it during the course of the years. And interestingly enough, she had vision loss due to retinal bleeding and retinal detachment. And she has an older brother, so she comes from a consanguineous family. She has an older brother who had similar problems. He passed already away, but he had also liver failure, leukemia, and this all fits into something that's called Coats Plus syndrome. So the diagnostic hint for that was the retinal detachment, and this is a telomeropathy, and there are 17 genes that can cause it. So we need to do next generation sequencing in order to find out which of the 17 genes it is, because you cannot make a differential diagnosis just based on the clinical diagnosis. So again, this is an application of next generation sequencing. Finally, insist on clinical suspicion. Next generation sequencing is not always giving you an answer. You have to be critical. This is a female with intrauterine cerebral cysts, and when the child was born, there was severe, almost intractable lactic acidosis. The child was really very sick and also developed a pulmonary hypertension, which was the life-limiting problem in this child. So the child passed away after a couple of weeks. Of course, we did exome sequencing because we thought this must be something mitochondrial with the lactic acidosis, but the whole exome sequencing was negative. We didn't find any gene. And then we reevaluated critically, and we also found out from the literature that pulmonary hypertension is also part of mitochondrial disease if it's caused by complex 1 deficiency. And we went back to the lab and we asked them, we said, look, please look again at that exome. And then they came up with the diagnosis, and this is FOXRED1. And we were able to confirm that this is really that problem in skin fibroblasts. So here you see, again, the value of exome sequencing. This is complex 1. So complex 1 is part of the respiratory chain enzyme, and it consists of many genes. So there are more than 50 genes that all together are important to make that complex 1 work. So these are all the genes. The yellow ones are mitochondrial, the other ones are nuclear coded. But here, these kind of squares, these are all genes that are not directly involved, but they are important for the assembly of this complex. So if you don't have these genes, the complex just cannot be put together. And here you have the FOXRED1, which is one of those genes that are important for the assembly of the gene. So this patient has a complex 1 deficiency because the assembly doesn't work. Again, only few patients in the world diagnosed. Ours is the third. And the two also had pulmonary hypertension. Last example, next generation sequencing. What is the value of whole genome sequencing? Whole exome sequencing just looks at all the exomes, at the coding parts of the genes. Whole genome sequencing looks at everything, also at the non-coding. And non-coding parts are much, much more than the coding parts. And this is a 2-year-old female who was hypotonic from birth, had severe swallowing problems and severe sleep problems. I never have seen a baby with such a severe sleep problem. She just wasn't able to sleep at all. She was initially treated with chloral hydrate, which didn't work. And then finally she was treated with gabapentin, which worked a bit better. And she also had dyskinetic movements, and the dyskinesia of the eyes was shown as eye rolling, and we were not sure whether it was seizures, but we found that it were not seizures. And she also has progressive cerebral atrophy. So we did exome sequencing in this girl as well, because we thought, well, that might be something mitochondrial. And then we found a variant only on one allele, the SEP6 variant, which is a variant that causes, if it's on 2 alleles, that causes pontocerebral hypoplasia. But we only found it on 1 allele. And then finally, we did exome sequencing, whole genome sequencing, and in the whole genome sequencing, we were able to find a problem also on the other allele. So it's an autosomal recessive disorder, and we were able to establish this diagnosis in this child. Again, for this family, this was very important because they're very young and they won't have 2 more children. And this is a good way how to do a prenatal diagnosis. Finally, the treatments. So I started out with tight treatments, the traditional treatments, the ones for the treatable intellectual disabilities, like medical diets. We spoke about gum deficiency, cofactors, supplements, small molecules, and we also have a few treatments, stem cell transplantation, enzyme replacement therapy. But there is a huge amount of new therapeutics. So, and this is due to many orphan drug approvals since 1983, when the Orphan Drug Act was implemented. So there were many new conditions that were approved for treatment, and most of the subspecialties were oncology, neurology, endocrinology, and also metabolic diseases. So metabolic diseases had a lot of new treatments. So that's why we got lots of enzyme replacement therapies. Between 2010 and 2016, we can treat now patients with mucopolysaccharidosis type 2, 4, and 6. And there are a few other disorders which we can treat with enzyme replacement therapy now. And these are the enzyme replacement therapies that we had already before 2010. And in addition to these new treatments, there is an enormous development in next generation therapeutics. They are in the pipeline. Many of them are just before approval. And some of them, for example, are aiming to penetrate the blood-brain barrier. There are some treatments, particularly enzyme replacement therapies, which are not good for children who have problems in their brain because the enzyme doesn't go into the brain. But there are now new technologies that help to bring those enzymes or other drugs that otherwise would not pass the blood-brain barrier into the brain. There are small molecule therapies, which are kind of medications that try to help to stabilize an enzyme in the cell and to make it more functional. There are gene replacement therapies and gene correction therapies. So there's lots of things that are ongoing, and I haven't even mentioned everything that happens in that field. But how to create evidence for these conditions, for these new treatments? So we see it already in those treatments that we have already available, in the tight treatments, that for more than 60% of those traditional treatments, diets, cofactors, they are only at an evidence level of 4 because the correct studies were not done. And it's difficult to do randomized controlled trials for a disease like for GAMP deficiency, where you have only 100 patients in the world. So that's why we need at least high quality guidelines for existing therapies. We have a demand for clinical sites, for industry-sponsored trials, for the new treatments. These are most of the times are multicentric trials in order to get enough patients into a clinical trial. And there's also a demand for innovative approaches like N-of-1 trials, where you have only one patient, but you want to try a treatment in that one patient and to create a proof of principle, for example, which might lead to a larger trial. So we have been involved in a couple of those kind of activities. We have a Canadian inherited metabolic diseases network, where we have a Canadian database of many of those conditions, and where we can track the outcomes of those patients. We are participating also in rare phase 3 trials. So we have one patient who is on intrathecal enzyme replacement therapy for mucopolysaccharidosis type 2, and we do a couple of innovative therapies, and more to come. So frequent questions and answers. This is the last part of my presentation. So how do we obtain consent for whole exome sequencing? This is something that's really a challenging question. So the first thing, the patient needs to know what are the result scenarios. They shouldn't have too many expectations. So they need to know it can be positive or negative. You can still not find anything. There are many instances where we have a finding of unclear significance, variant of unclear significance, which means that potentially it could cause the problem, but we don't know enough about the gene or about the type the gene has the defect. And then we also can have those unexpected findings. So we can find something completely different from what we had initiated suspected. So we had a patient in NICU who presented with neonatal lactic acidosis with parenchymal bleedings. He was really very sick, and we thought that he has a mitochondrial disease, and then we did whole exome sequencing, and then nothing was found with mitochondrial disease, even after critical discussion with the lab. So we found something that's called GATA3 deficiency, which causes familial hypoparathyroidism, sensorineural hearing loss, and renal dysplasia. And this child indeed, we found out that he has a low parat hormone, and that he has kidney cysts, and that he has sensorineural hearing loss. We wouldn't have found that out because of that initial presentation. And then you can have those secondary findings. And this is really a challenge for us because particularly the US-based labs, and we send everything into the US, they give the patients the option that they can opt in or out to have results about secondary finding. And these secondary findings is about 59 genes that have been identified by experts that are most of the time totally unrelated to the child's health concerns, but that are conditions that might manifest later in their lives, but that might be treatable or preventable. And these are mostly cancer genes and heart disease genes. And some of the labs also give the option to the parents to have those kind of secondary findings tested in themselves as well. And this, of course, gives you a lot of troubles with genetic counseling, with telling the patients when they come back. So it's a true challenge. In Canada, the secondary findings are not generally recommended, but as we're dealing to a certain degree with US law, and there they are, the labs are obliged to offer that to the patients, so we have to offer it to the patients as well. Fortunately, we have never found any secondary findings so far. Also, surprisingly, most of the families opt for those secondary findings, even if we tell them that it could cause some troubles to know that somebody is at risk for hereditary cancer later in life. Many of them really want to know everything. And the other thing is the genetic discrimination. We have some families who initially are interested in next generation sequencing, but at the end of the day, when it comes to the blood work, they opt out because they say, well, we thought about it and we're just afraid that, that this might affect the insurability of our child or of the family. And that's interesting because there's only very few cases of genetic discriminations who have been published. So mostly families with Huntington's disease, where there has been discrimination in affected carriers who were not yet symptomatic, or also in people with breast cancer genes. But as far as the publications and as is known, it's not very frequent. But still, there is the fear of everybody, and that is why in Canada now we have a Canadian genetic non-discrimination law. And this law actually says that insurance companies or employers do not have the right to access the genetic information of a patient. However, of course, this is a two-sided thing, because of course, they're still entitled to ask for the health information, and with the health information, that's even more important than the genetic information. What we are saying to our patients is that what we are not doing predictive genetic testing. We don't want to know what happens with a child in 10 years. We want to know what is the cause of the current condition, and the current condition is there, and this will be available to any insurance company. So finally, just for a discussion, so I wanted to show you how our patient profiles have been changed since 2005. At the beginning, when I took over from George, we had metabolic patients with these classical metabolic diseases. We kind of tried to expand our spectrum because there's so many patients who have a metabolic disease who also have neurologic problems. So we expanded to neurometabolic diseases, and finally, with the TIDE project, we also included patients with intellectual disability into our caseload. As I hope I was able to show you, now with these new omics tests, we have a totally different category of patients that have these omics defects. And these patients are really complex, not only the patient's symptoms and the syndromes of the patients, but also the results of those tests that we're doing. And most of those patients have extremely rare conditions, even if we are able to establish a diagnosis, as mentioned with that FOXRED1. It's a nice diagnosis, it explains everything, but there are only 2 patients in the world. So we have to follow up and learn about the individual natural history. So we cannot just say, well, we have the diagnosis, and if there's no treatment, we can't do anything, but we need to follow up, and we need to learn from the patients how these diseases evolve. And this will also help us to tailor the individualized care and to do something, that everybody now calls precision medicine. So it's a lot of patient care that is associated with that. Then we have lots of patients with those variants of unknown significance. For this, we have to track the classification, because the more patients will be screened with whole exome sequencing, the more we know whether the variants of unknown significance are really unknown, or at a certain point they might turn into of known significance. So how do we track that? How do we, for example, after a couple of years, if a patient comes again, do we have to look again into all the databases and see is the diagnosis still correct, or do we have to say now we know that that gene defect is really causing your child's problem? So that's a lot of work. And of course, they have complex organ involvement. as you saw with those few cases, they need multidisciplinary care. And this is why I think we have to make with you a mutual care plan for those patients. How can we together look after those patients, both from your side and from our side? And I think this is a big discussion that needs to be started now. I appreciate that just writing some clinic letters and sending some recommendations is not enough. On the other hand, keeping all the patients in our care will also not work out. So lots of things to do with these new tests. Finally, this is not even the whole team. So this, all these photos are from the team as it was in early 2017. Now there have already been some changes, and this is actually just to remind us all that that it was Clara with whom we were able to build up the TIDE project, and on which we are building now. Thank you very much for your attention.
I'm just noticing that you have 23 women there.
Yeah, sure. We are only women. Yes, I think last year we had, for half a year, we had one male fellow, and
that's nice.
everybody loved him.
So, from a clinical standpoint, I get these teenage boys, usually boys, not always boys, usually boys, with atypical autism of various types, intellectual disabilities that have basically gone through a variety of clinical evaluations, never really having had a metabolic or genetic testing of any kind. And I can't say I've taken the initiative to get the ball rolling on this. So I'm just wondering, from your standpoint, what would be an appropriate approach in terms of screening them if they don't have obvious craniofacial or obvious biochemical abnormalities on their usual blood screenings?
Yeah, that's really a tough question. I think with those autistic children, particularly the high functioning, I'm not aware that we were able to make any diagnosis in those patients.
They're not so high functioning.
I think if it's associated with intellectual disability, the chance to get a diagnosis, a genetic diagnosis, is higher. But again, I think it's a little bit about resources as well, because they are so unspecific. So you really have to do an exome, and on a clinical basis, it's probably not easy to get it funded. I mean, an exome costs at least $2,000. That's the cheapest one at the moment. So we have to apply for those exomes on an individual basis. So with every single child that we do an exome, we need approval from MSP. And the approval, we obtain it if we can make some kind of case that it might be treatable or that it might really change the management of the patient. That will definitely change in the future because these tests will become cheaper, will become widely available, but we still have to do some triage for that. So we haven't done lots of those patients that you're alluding to.
The other question is related to this, is the cost issue, because obviously the younger you detect them, the better.
Right.
So ultimately, are you headed for universal screening of newborns?
Well, there are people who work on whole genome sequencing as a newborn screening technology. So, the question is, will the whole genome replace the current traditional metabolic tests? Looking at amino acids, acyl carnitines. I don't know, but that's something, there's lots of research ongoing with that. And of course, then you would probably find it. Again, it will depend on what you're looking at. Probably if you have a whole genome or whole exome as a newborn screening, you would probably look at certain conditions, and also you have the information for more.
I'm wondering where Fragile X screening comes into the workup of people with intellectual disabilities. I feel like when I read about it, it's sometimes quoted as the most common cause of intellectual disability, and I feel like I've ordered more than 1,000 of them and never gotten one. So.
Yeah, exactly. I haven't mentioned the Fragile X screening because that's a different technology. So it's not microarray, it's not exome, it's not metabolic testing. So it's a different test. We did in the TIDE protocol. We didn't do it on a routine, so we didn't do it on a standard basis. But I agree. I haven't seen many patients either. I just saw one very recently who really had a Fragile X.
Textbooks say it's very common.
Yeah, I don't know. Yeah, no, but I mean, it probably, I mean, I just can say from.
Should we be doing it more based on phenotype than this? So I guess my practice in the past has been sort of to just add that on for autism and intellectual disability in a boy. And maybe I should be looking more for phenotype in the.
I think if we do it based on a phenotype, the diagnostic yield will definitely be higher. Yeah. Yeah.
But I think it points to something important, which is that even when you just flashed up there, just sort of as your background information, that I forget which tier it was, but that, in a child with intellectual disability, we would do an MRI. So at Sunnyhill, we don't. In neurology, we do. So there's no consensus across the province about how we investigate intellectual disability. And I think it would be a great thing to do, because I think that's probably why everyone's here tonight, is going, what do we do with all these kids? And if when we see the 14-year-old, do we still go back and do a full TIDE workup? Or when we do the microarray and we get those unexplained variants and you go, wow, you have this whole piece missing, and they're telling me that this isn't what's causing your intellectual disability?
Yeah.
And what do we do with that? Do we then say, okay, come and see you, or come and see Suzanne Lewis and get whole exome sequencing? I think we kind of need
I think that, we were thinking a lot about that, about a more kind of, a more generalized protocol for workup of intellectual disability. But it's difficult to get to a consensus. So what is true is that there are the practice guidelines. They have been published both from the American Society of Medical Genetics and from the pediatric societies. And these practice guidelines, they uniformly say, you should do a microarray, you should do an MRI, you should do hearing and vision test, and a few other things. So, of course, it doesn't mean that just because these are the practice guidelines that you can't do that in every single patient, because it's just maybe an overkill. If you do in every patient an MRI, you still have to make some clinical decisions whether the MRI, makes sense because you have some kind of neurologic symptoms. So I think it's really difficult. It's a matter of invasivity, because MRI needs anesthesia, and of a matter of resources. And so the good thing about TIDE is, of course, it just catches, those patients with treatable diseases, but it gives the patients an entry into the system. So as you might have seen, we're seeing many patients where the TIDE workup is normal, and where we do more testing and then we find a diagnosis. So I think the TIDE is something that gives the patient an entry in the system, and on the other hand, gives you some kind of confidentiality, that gives you some kind of a good feeling that you haven't missed anything that's really treatable.
You mentioned right at the end, Sylvia, about working in collaboration with the community physicians. Is there any place in North America that has a really good model of that that's working, or do we have to invent that?
Yeah, I don't know actually whether there's a place. I mean, in the United States, it's often such they have these big centers. They have a center for 1 year rare disease and a center for other rare diseases, and then all the patients are referred to those centers, and they are part of research studies, of natural history studies. I don't know whether they have good models for that, good clinical care models. But I have had a couple of conversations with Alice and Eddie about that also, and I think we have to get into conversation with you guys and to see how can we communicate in a way about the patient that you feel comfortable with taking them back, and that that there's this kind of mutual communication. I think it's just something I think we have kind of to, at least to semi-invent it, because I don't think that there's a good model. And it cannot be, because all these tests, this whole exome sequencing, this is, I don't think that anybody has already a model for that. George.
Thank you very much, Sylvia. This was enlightening and interesting. I noticed that you had one group that there's coexistence of autism and celiac disease. And you probably know already that in the celiac group, there's a lot of folk knowledge that autism can be treated with gluten-free diet, or that autistic kids have celiac disease. I wonder if you would have thought of, or might think of screening that group of patients, so you would get at through the Canadian Celiac Association.
Yeah, no, we haven't done that. No, but that's a good idea.
The idea of funding only screenings for treatable conditions, to me, if the cost is really $2,000, say, seems to me it should be challenged. If you had a child who, we could accumulate a group of kids with the same condition, and maybe that non-treatable condition would become treatable at some point, as PKU didn't used to be treatable. And the other is, even if it does, if it were your son, wouldn't you like to know that they had a specified neurologic, genetic, metabolic condition that explained this life that they've lost?
Yeah, this is what we are experiencing with most patients, that they are, even if it's, they are extremely grateful for a diagnosis because they just have a label on it. And, and as long as there are more than 2 patients in the world, they have the feeling that they are not totally on their own. And it also helps us physicians, to kind of give a little bit more information on the prognosis, even if there are not many patients. But if we understand the function of the gene, I mean, we can make some assumptions, and that's definitely
that we spend for a gravely disabled kid, and all the money that they use up is a pittance.
Yeah, absolutely. Yeah, I think that disabled children definitely deserve it. Yeah.
Thank you for the great talk, Dr. Stockler. I'm one of the residents, and on my NICU rotation recently, I had 2 or 3 families